So hello everyone, hope you're all doing good. In this video, we are going to discuss about one of the most important commonly performed obstetric surgery is Cesarean section. See, in Cesarean section, we are going to deliver the baby by giving two incisions. Okay. So the first incision is a laparotomy incision and a second incision is a hysterotomy incision. Now, what is this laparotomy incision and hysterotomy incision? Laparotomy incision means an incision which is given on the abdominal wall. Okay, whereas hysterotomy incision is an incision that is given on the uterus. Okay, so this is very important because you have to understand that in India, the national rate of Cesarean section has arisen from 17.2% to 21.5%. Okay, so this was according to the recent NFHS criteria. NFHS criteria in 2019 to 2020 says this ratio. Clear? So this was in 2015 to 2016. So you see how much increase is there. Okay, so it is very important to know about Cesarean section and what is the ideal indication for performing Cesarean section also. Clear? Right. Now, we'll see the types of Cesarean section first. So, types of Cesarean section include, we can call it as a primary Cesarean section when it is performed for the first time in a pregnant woman. So, it is otherwise known as repeat Cesarean section when it is performed after first delivery, that is in women who had one Cesarean section. Clear? Then, if we see the types of Cesarean section, we have LSCS, that is lower segment Cesarean section, where the incision is made in the lower uterine segment and it is called as classical Cesarean section when we are putting a vertical incision in the upper uterine segment. Clear? The other types of classifying Cesarean section is according to the time of planning of Cesarean section. It can be an elective Cesarean section or a planned Cesarean section, where the risk, okay, either maternal risk or a fetal risk is anticipated in the antenatal period itself. And the next one is emergency Cesarean section, where it was done due to intrapartum risks. And sometimes we perform according to CDMR also. CDMR means Cesarean section, okay, based on maternal request. On maternal request. Okay, this is Cesarean delivery. Okay, Cesarean delivery based on maternal request. Okay, without any known obstetric or any other fetal indication, we are going to perform Cesarean section only according to the maternal request. Yes. Now let us see some of the repeating. Now let us see some of the common indications for Cesarean section. So indications of Cesarean section can be classified into absolute indications and relative indications. Okay. So absolute indications of Cesarean section include when there is central placenta previa, there is contracted pelvis or cephalopelvic disproportion, when there is pelvic mass obstruction, like example when there is a broad ligament fibroid, there is advanced carcinoma cervix, there is vaginal obstructions. Okay, suppose there is vaginal stenosis or atresia. Clear? Then we will see some relative indications of Caesarean section. So, relative indications of Caesarean section include prior Caesarean delivery, then if there is non-reassuring fetal heart rate or fetal distress, there can be dystocia, antepartum hemorrhage like placenta previa or abruption. When there is malpresentation like breech delivery, or even when the lie is abnormal like transverse lie. Then when there is failure of induction of labor. Okay. So, these are some of the indications. Also, you can include your active herpes genital infection. Okay. So, that will come as a absolute indication. Okay. That is an active herpes in the mother. Clear? I wanted to know about Robson classification also, which is a classification of Caesarean section based upon the parity, the presentation of the fetus and the gestational age, etc. Okay. So, this is Robson's classification. So, if you see here, we have 10 groups according to the clinical characteristics. Okay. So, the first group is a nulliparous woman with a singleton pregnancy having a cephalic presentation, and the gestational age of the fetus is more than 37 weeks and she is in a spontaneous labor. Okay. And group 2 is a nulliparous woman, singleton pregnancy, cephalic presentation that is more than 37 weeks or equal to 37 weeks with induced or Caesarean section before labor. Okay, before labor itself we are planning Caesarean section for her. Okay, so that is the difference making. And the third, fourth, fifth will be going for multiparous women with the same criteria. So, multiparous woman without previous Caesarean section. Okay, that means she had a normal delivery in the prior delivery, and she had a singleton pregnancy. She has a singleton pregnancy with a cephalic presentation more than or equal to 37 weeks, and she is in spontaneous labor. Right? And the fourth group is multiparous women without a prior Caesarean section. But what is the thing here is will be having induced labor or Caesarean section before the labor itself, right? And the fifth category goes for multiparous women with prior Caesarean section with a cephalic presentation and the gestational age is more than or equal to 37 weeks, right? So, here comes previous LSES. Okay, fifth category is previous LSES. And then sixth category goes for the breeches, because when you write B like this, it seems like a 6, okay, like that you can remember. And the seventh category is about all multiparous breeches. Okay, so 6 and 7 will be going for breeches anyhow. 6 is for nulliparous breech and 7th is for multiparous breech. And 8th one is all multiple pregnancies, okay, many pregnancies. So, 8, if you see, there are 2 rounds, okay, so multiple pregnancies together, okay, maybe a twin pregnancy also you can imagine. And 9th group is all pregnancies with repeating, and the 9th group is all pregnancies with transverse or oblique lie, okay, including those with previous Caesarean section. So, when the lie is abnormal, then it will be coming in the 9th group. And the 10th group is a singleton cephalic presentation that is less than 36 weeks, including previous Caesarean section. So, this will be preterm labor. Clear? Okay. So, 1 and 2 about nulliparous, 3, 4, 5 is about multiparous, 6 is about 6 and 7 are about breech, 8 is about multiple pregnancies, 9 is about transverse or oblique lie, and 10th is about preterm labor. Clear? So, Robson's classification is also very important. Now, we will see what are the prerequisites while preparing for Caesarean section. First thing, any procedure or surgery, you have to obtain consent. Okay, so that is the prior thing. So, obtain consent, then you have to inform the anesthetist and obstetrician Number 3, you have to perform NPO for the patient. So, stop the solids 6 to 8 hours prior, and liquids can be given up to 2 hours prior the cesarean section. You have to get IV access, okay, and then you have to do skin preparation. Skin preparation by using regular soap is also enough. You have to do clipping of hair on the site of surgery, okay, because you won't be doing shaving, okay. Shaving of hair is contraindicated because it can rise to infection, okay. Then you have to give pre-medication. Pre-medication has to be given with H2 receptor antagonist, H2 receptor antagonist, because this will help in raising the gastric pH, okay. So, that will prevent lung injury if in case aspiration happens. Clear? Then, so what is that chemical pneumonitis called? It is called as Mendelssohn syndrome. Mendelssohn syndrome, which is nothing but a chemical pneumonitis. You have to give regional anesthesia. You can prefer to give spinal or epidural. Then definitely will be giving prophylactic antibiotics. This will help in reduction of infection that can lead to endometritis or wound infection. Clear? Yes. Now, which antibiotic we can give means, we can give single dose of IV cefazolin. So, with the women with the normal weight, 1 gram dose of cefazolin is also enough, but in case the woman is overweight, we have to give 2 gram dose. Clear? So, this is the first option. And the second option is, you can even prefer to give cefuroxime as an alternative. You can also prefer to give cefuroxime as an alternative. You can also give IV clindamycin and IV gentamicin if there is a history of penicillin allergy. Clear? Yes. Now, not only this, we have to consider prophylactic anticoagulation also, because post surgery she is going to be in a prolonged bed rest, right? So, what about prophylactic anticoagulation? Because she is at a high risk for venous thromboembolism. Clear? So, what are the high risk features for giving prophylactic anticoagulation? If there is a previous venous thromboembolism, when there is a high risk for thrombophilia, when she is overweight woman, BMI is more than 40 kilogram per meter square. So, you have to begin this prophylactic coagulation 6 to 12 hours post-operatively, okay, and it should be continued till ambulation, okay. So, what are the drugs you can prefer to give in anticoagulation means, you can prefer to give unfractionated heparin at a dose of 5000 units every 12 hours, right, and then you can give low molecular weight heparin also, that is enoxaparin, which can be given at a dose of 40 milligram subcutaneously daily, okay. So, these are the options of anticoagulation. And remember, among all these things, bladder drainage to empty the uterine bladder before the procedure and throughout the procedure is also important. So, don't ever forget to do that. So, bladder emptied, okay, by Foley's catheterization. Clear? Yes. Now, let us talk about the procedure now. But before that, I just want you to recall about some of the anterior abdominal wall anatomy, right? Repeating. Now, let's talk about the procedure of cesarean section. But before going into the steps, I just want you to recall the anatomy of anterior abdominal wall. Okay. So, these are the layers which we are going to cross before reaching the uterus and delivering the fetus. Okay. So, we have the layers like skin, then you have two layers of superficial fascia, you have a superficial layer called, so you have skin followed by two layers of superficial fascia. One is called as a campus fascia, another one is called as corpus fascia. Campus fascia is a superficial fatty layer and corpus fascia is a deep membranous layer. And then you have muscles and fascia. Okay. Then you have the transversalis fascia, you have extraperitoneal fat and parietal peritoneum. Clear? And remember this concept also, you have to cross the rectus sheath before going and delivering the fetus. But remember, we will be giving most of the incisions in cesarean section lower to the arcuate line. So, remember that most of the incisions of cesarean section are given below the arcuate line. Arcuate line is a space that is midway between the pubic symphysis and the umbilicus. Okay, so below the arcuate line only we are going to give most of the incisions. The importance is that above the arcuate line, what is going to happen is the rectus sheath is going to split like this. Okay, the fascia from the internal oblique muscle is going to split both above and below the rectus muscle. Okay, and it is going to cover it on both the sides. Whereas below the arcuate line, that is not going to happen. Okay, so rectus sheath below the arcuate line, all tendons are going to pass anterior to the rectus abdominis muscle. Are you able to see? So this arrow mark is not mentioned in downwards here. Clear? So this is so after this explanation, I am repeating. Okay, I will be continuing now. Now, let's see the procedure steps outline first. Okay, so if we see the procedure steps outline, we'll be doing opening of the abdomen and then we'll be doing closure of the abdomen. So, while opening, we have to open the skin, subcutaneous tissue, rectus muscle along with its sheath. We have to go through the peritoneum, then uterus. Also, after uterus, we will be delivering the fetus. Clear? Then closure should come in reverse, right? So, we will be closing the uterine wound followed by the peritoneum followed by the rectus sheath and then the subcutaneous tissue and then the skin finally. Clear? Do you understand it now? Yes. So, mostly we will be giving the patient a supine position with a left lateral tilt at least some 10 to 15 degrees. This is to prevent the aortocaval compression by the gravid uterus, right? So, for this we can either tilt the table laterally or we can place a folded linen under her lower back, right side. Okay. Then another important thing is fetal heart rate should be checked on the table once before commencing surgery. You have to do examination of the abdomen also before giving the incision to know about the presentation and lie of the fetus. Then, if there is any dextrorotation, that has to be corrected. Okay. So, these are the steps you have to know. Clear? So, we will see cesarean delivery techniques. Cesarean delivery techniques. This include fan and still, Kerr method, Joel-Cohen method, Misgar-Ladach method, and then the modified form of Misker-Ladach method. Clear? Now, so these are the various type of skin incisions that are given for cesarean section. Okay, so you can give placental incision or a Joel Cohen incision or a midline vertical incision. Okay, one more incision is Maillard incision. Just will be giving in a curved manner, but a little higher away from the pubic symphysis. Okay, so this is your Maillard incision. Clear? Yes. So these are the various types of incisions. Now we'll see one by one. First one is a phalansteal incision. So we'll see all these incisions now. So if you see phalansteal incision, this is a concave incision with concavity upwards, and it is a slightly curved incision. Then if you take Joel Cohen incision, so this is the Joel Cohen incision. So this incision is going to be a straight incision, that is 3 centimeter below the anterior superior iliac spine. Okay, so 3 centimeter below that, and then it is somehow cephalad to phalansteal. Okay, then we have Maillard incision. The importance of this incision is that you will be transecting the abdominal muscles here. Okay, transecting the abdominal muscles especially the rectus muscle. And then we have a midline vertical incision also. Okay, so this midline vertical incision can be a midline incision or it can be paramedian incision, but it is rarely used. Okay, now we will see the advantages and disadvantages of the transverse incisions and the vertical incisions. First, let us see about the transverse incisions. Transverse incisions advantages include they will be following Langer's line. So, you have a superior cosmetic results. There is less postoperative pain or less chance of wound dehiscence, and this can lead to low incidence of incisional hernias. Okay, we will see the disadvantages now. So, these are the advantages. Okay. When we talk about the disadvantages of transverse incisions, see, while giving transverse incisions, there can be injury to the nerves, there is increased rate of infection, and we have only a narrow field of exposure for operating. Clear? We will see the advantages and disadvantages of vertical incisions as well. So, when you take vertical incisions, advantages of vertical incisions include we can have a quick entry, there is minimal blood loss, we have a wider operating space, then you can even have flexibility for easy wound extension. Yes? Okay, so these are the advantages of vertical incisions. Now we will see the disadvantages as well. So disadvantages include there is a higher risk of facial dehiscence and rupture in the next pregnancies. Then there is a poor cosmetic results. Then there is a greater risk of postoperative pain. Okay. So, these are the disadvantages. Clear? So, we have seen about the skin incisions. Now, we will check about the subcutaneous layer. Okay. So, how we are going to incise the subcutaneous layer means we will be giving a blunt or short dissection. Here, you have to remember the blood vessels are more. So, if needed, you can even cauterize the blood vessels here. Then, remember, even if you are using cauterization, judicious use is recommended. Okay, judicious use of cautery is recommended. Then, we have to incise the rectus fascia. So, here what we will be doing is we will be giving an incision in the midline with a scalpel. Okay, incision in the midline with a scalpel. Then this is extended laterally, and then the fascia should be dissected off the muscle without damaging them. Clear? Then in some cases, so we will see the opening of peritoneum now. What we will be doing is, after cutting the rectus sheath, we will be opening the rectus muscle bluntly, and then the peritoneum has to be opened. Clear? Now, while doing this, care to prevent bladder injury should be there. Clear? Yes. And the next one is about the bladder itself. With the bladder, you have to create a bladder flap. The peritoneum, that is overlaying the bladder and the lower uterine segment. Okay, so it will be like this. So we know you have the uterus here. Okay, anteriorly you will have the bladder somewhere here, right? So what happens is that you will be having a peritoneum between these two. Okay, so like this the connection will be there. Okay, and this peritoneum should be excised off separately. Clear? So this can be excised of the lower uterine segment either bluntly or sharply as you need. Okay, so peritoneum excised. Excised means, in other words, more precisely, it is dissected off, okay, from the lower uterine segment, either bluntly or sharply. Now, after opening this, we will be reaching the uterus. Now, what we are going to do? Yes, we are going to perform hysterotomy, that is nothing but the uterine incision. So, before giving uterine incision, as I previously said, correct dextro rotation once again if needed. Okay. Now, you have to do the hysterotomy incision in the midline, okay, and not laterally, definitely not laterally, okay, and most of the times we will be giving a small curse incision like this over the uterus, and other incisions are also available, like there is T-shaped incision, J-shaped, U-shaped incision or J-shaped incision. So, all these are not preferred regularly. Okay. So, which incision will be preferring mostly? Yes, we will be giving a low transverse incision over the uterus. Okay, because it causes less bleeding, it is easier to repair, and it causes less adhesion formation. Clear? And then low vertical incision can be used if any complications are anticipated. For example, in breech. Okay, complication with the extraction we can say. Okay, and another type of incision we can give is a classical Cesarean incision. Classical Cesarean incision is an incision which is given along with the longitudinal axis of the uterus from the upper uterine segment to the lower uterine segment, and this is mostly given when lower uterine segment is not accessible or there are severe adhesions that you cannot approach the lower uterine segment, etc. Clear? But most of the times classical Cesarean section has to be avoided because the chance of rupture uterus with the classical Cesarean section in the previous delivery is more with the future delivery. Clear? So these are the types of incisions we have discussed in the uterus. So we can have a low transverse uterine incision or a classical uterine incision, okay, which is a straight one. This is a T incision of the uterus, and you have a J-shaped incision, okay. Can you see a J shape here? So likewise it comes, right. So this is a J-shaped incision, right, J-shaped incision. You have a you can even have a U-shaped incision, or this is an inverted T-shaped incision. Clear? So suppose you have the incision in the uterus like this. What you have to do is you have to insert both your fingers like this on both the ends of the incision, and you have to try to extend the incision laterally and capillaterally. Okay. And remember, adequate incision on the uterus is very important for easy extraction of the fetus from the uterus. Clear? Right. Then, so this is how we deliver the baby with the vertex presentation. So we have entered the uterus, and then what we are going to do is we are going to use our hand as a scoop, and we are going to hold the fetal head, and just like taking a scoop out, we are going to use our hand and take the fetal head out. This will be following the shoulders, and finally the rest of the fetus will be following without any difficulty, and after that we have removing the placenta and closing the uterus. Okay, so this is about vertex presentation. And then we have sometimes a complication called deeply impacted head. Okay. So delivery of deeply impacted head can be done by a technique called Patwardhan technique. This is mostly done in occipito-transverse or occipito-anterior positions where the deep impaction is possible. So in Patwardhan technique, what we'll be doing means, we'll be seeing the fetal shoulders, okay, under the uterine incision first. Okay. So what we'll be doing is we'll be delivering the anterior shoulder first, followed by the posterior shoulder. Then we'll be leaving the hands under the axilla of the fetus, and we'll be delivering the rest of the fetus as a whole. Still the head is inside, deeply impacted. Now what we'll be doing is, since the rest of the fetus is extracted now, we'll be using the legs of the fetus to hold and bring the deeply impacted head out. Okay, so this is Patwardhan technique. So let me write it once again so that you will be able to understand. So first one, I told you fetal shoulders are seen at the level of incision. Then first the anterior shoulder is extracted, followed by posterior shoulder. Then we will be using the fingers of our hand to hook through the axilla of the fetus and bring the body of the fetus out. Then we will be giving traction on the leg of the fetus so that we will be delivering the head now. Okay. So if this technique is to be performed, you can even give a T-shaped incision or a J-shaped incision also. Clear? Right. In breech presentation, what we'll be doing is, we'll be gripping the hip of the baby or the feet of the baby, and we'll be trying to bring the baby out. Okay, some gentle traction is needed until the shoulders, and then we can use a towel also to have a very good grip. And following that, you have to deliver the arms. Okay, so what you will be doing is, you will be sequentially sweeping out the arm one by one out, and then you have to bring the head of the fetus also gently by gradually extracting the fetus through the legs. Okay, sometimes there can be need of forceps or use of Marisolus Milliviate method also. Clear? Yes. So number one, we have to deliver the fetus by either gripping the hip or feet to bring the fetus out of the uterus. Then I told you the fetus is delivered up to the shoulders with gentle traction and sometimes there can be a assistance with the help of towel also, okay, to get a very good grip. That's it. And then we will be delivering the bilateral arms which are sequentially swept down and delivered, and following that sometimes even you can give fundal pressure, okay, for the delivery of the head, okay, or even you can use a forceps, okay, or sometimes Mauricio smelly Wyatt method can also be employed. Clear? Right. Now we will see the umbilical cord. Don't forget about clamping and cutting the umbilical cord. Okay. Repeating. After this, don't forget about double clamping the umbilical cord and cutting it. Okay. So double clamp and cut. Then we have to deliver the placenta as well. So mostly spontaneous delivery of placenta will be happening. Otherwise, you can go for manual removal with controlled cord traction and fundal massage if needed. After delivering the fetus, you have to use a clean towel to clean the uterine cavity to get rid of all the meconium and vernix gaseosa, etc. Clear? Right. Then, now we will see about closure. Okay. So, how will be doing closure of abdomen? So, for closure of abdomen, uterus can be exteriorized, okay, that is it can be brought outside the abdominal cavity and closure can be done, okay. Usually we will be using delayed absorbable suture and running closure can be used, that will reduce the time as well as blood loss. If you ask me if there is a need of single layer closure or a double layer closure, the data is mixed actually. So, some prefer to do single layer closure and some prefer to do double layer closure because this is a traditional one and this has a recent advantage. Then you have to secure hemostasis. Then posterior cul-de-sac is cleared of blood or fluid, whatever it is present. Clear? Right. Then we have to close the peritoneum as well. So, this also depends upon the surgeon's preference because the data is mixed. And about the muscles, actually if you do a closure of muscles, this will reduce the risk of subsequent diastasis recti. And decreases intrauterine adhesion formation also. Okay, but if the muscles are closed, there is increased risk of post-operative pain. Next one is rectus sheath can be closed with a delayed absorbable suture as well. You have to do it in a running, non-locking fashion. Interrupted suture is not preferred that much, okay. And then for skin suturing, we can do subcuticular or mattress sutures using monofilament. Surgical staplers are also another option. Clear? Now we will see about the difference between all the 4 types of cesarean section. I already told you we have financial care method, okay. Then we have Joel Cohen method, then Miscov Ladach technique and modify Miscov Ladach technique, right. So, if you see the skin incision in financial care type, we will be giving a financial incision, whereas in Joel Cohen and modified Ladach will be giving Joel Cohen incision, and a modified Miscov Ladach technique means we will be giving a financial incision again. Clear? And then for the subcutaneous layer, fascia and the peritoneum. Okay, we'll be doing a sharp dissection in case of phalansteal cut type, whereas we'll be doing a blunt dissection in case of Joel Cohen modified Ladach and modified Misgut Ladach technique. Okay, then if we take the uterus, first we'll be making a sharp incision followed by a blunt incision in all the 3 types. Then we'll be entering and delivering the fetus, and then we'll be removing the placenta. A manual removal of placenta is indicated in the phalansteal cut type under the modified Misgut Ladach technique, whereas it can be allowed for spontaneous delivery in the modified Misgut Ladach technique under the Joel Cohen type. Okay. Next is uterine closure. Uterine closure can be done in a single layer interrupted suturing in the first 2 types, that is phalansteal and Joel Cohen's, whereas here we will be doing a single layer closure only, but we have to do it as a continuous suturing. Clear? And the next one is about peritoneum. So, peritoneum closure is usually done in case of 1 and 4, whereas it is not recommended in case of 2 and 3, that is Joel Cohen and Misgut Ladach technique. Then what about the facial closure? Facial closure has to be done in an interrupted way in phalansteal incision and phalansteal cut type and the Joel Cohen incision, whereas we can go for a continuous suturing in case of Misgut Ladach technique and the modified Misgut Ladach technique. Clear? Repeating. Then about the facial closure, we can have a interrupted suturing in the first 2 types. Okay. Then continuous suturing can be done in the modified Misgut Ladach technique and Misgut Ladach technique. Then about the skin closure, mostly we will be preferring a continuous suturing, whereas in case of Misgut Ladach technique alone, we will be preferring a mattress suture. Clear? So, I hope this is about the difference between the various types of Cesarean section, and mostly these days modified Misgut Ladach technique is the preferred one because it is a combination of all the positive things. Okay. Then we will see now what are the complications of Cesarean section. So, complications of Cesarean section can include complications intraoperatively as well as postoperatively. So, we will see the intraoperative complications first. There can be utrovesical laceration or uterine atony. Sometimes there can be chance of uterine inversion also. Then there can be injury to the urinary tract or bowel, or there can be hemorrhage. And then postpartum complications after Cesarean section include, there can be postpartum hemorrhage, there can be paralytic ileus, and pulmonary complications can also be there like atelectasis or pneumonitis. Infections can be there can be urinary tract infection, endometritis, wound infection, and septic pelvic thrombophlebitis. We have to, so other complications include venous thromboembolism and foreign body. So, don't ever forget this complication. So, before closing the abdomen, you have to check for any sponges or mops or any needles or any instruments left inside the uterus. Clear? Right. Now, I want to discuss about Cesarean hysterectomy also here. Sometimes there can be a need where you have to simultaneously perform a Cesarean hysterectomy, okay, along with the Cesarean section after delivery of the fetus. So, some of the indications alone I am going to give you. So, indications include intractable uterine hemorrhage, that cannot be controlled by conservative methods, or when there is a placenta accreta spectrum, when there was a uterine rupture, or any gynecological conditions like CA cervix in the mother. Okay. So, for this we can perform a subtotal hysterectomy or a total hysterectomy. Sometimes there can be difficulty while during a cesarean hysterectomy because there will be edematous pelvic tissues including the broad ligament. Okay. And mostly this is associated with increased risk of maternal mortality and morbidity. These are increased. So, complications may include, therefore, there may be a urinary tract injury, or there can be a PPH which will be needing a massive transfusion. There can be chances of DIC, or there can be need of re-laparotomy, etc. Clear? So far we have discussed about cesarean section. So, how the layers are going to be opened, what are the indications, and what are the sutures we can use, and what are the complications also. With this topic itself, I want to complete about the previous cesarean section also. So, previous cesarean section deliveries can be given two options. Okay, one, you can go for repeat cesarean section, or you can offer them vaginal birth after cesarean section or trial of labor. Okay, so that is trial of labor after cesarean section, that is TOLAC. Okay, so what are the indications for repeat cesarean section if she already had a cesarean section? So these indications may include previous history of classical cesarean section, or previous history of ruptured uterus, or when she has undergone more than 3 previous lower segment cesarean section already, there was myomectomy or hysterotomy performed simultaneously. Okay, and if there is a cephalopelvic disproportion, or otherwise other indications as I have mentioned before. Clear? So, some of the relative indications also we can keep, like if there is macrosomia with the previous LSCS, right? LSCS, then there was breech presentation with previous LSCS, and also when it is a postpartum pregnancy that is more than 42 weeks with previous LSCS history. Clear? Right. Next we will see about TOLAC, that is trial of labor after cesarean section. So TOLAC means we have some ACOG criteria for TOLAC. Okay. So TOLAC can be given when there is one previous LSCS, no signs and symptoms suggestive of uterine rupture, then if there is physician availability 24/7, when anesthetist and blood bank are also available in the same setup, no other scars on the uterus. Okay. Now, we will see what are the contraindications of TOLAC. Contraindications of TOLAC include when she had more than previous 2 LSCS, or she had scar rupture, or when she had a classical cesarean section, or when there are other scars on the uterus, or any contraindication that is present for vaginal delivery. Clear? Right. So, we will see what are the factors that will be giving rise to success of TOLAC. Success of TOLAC depends upon the following factors, which may include if there is a spontaneous onset of labor. Induction is an absolute contraindication in classical cesarean section, remember that. Okay. And then when there is a spacing of 18 months, then she had a previous vaginal delivery, her postpartum period was uneventful, then if she has a normal BMI. Okay. So, finally, if we summarize for most successful indicator for TOLAC is if she had a history of previous VBAC. So, we have two outcomes for TOLAC. So, when you give TOLAC, you can either have a successful vaginal delivery or it can end up in emergency cesarean section. Okay. So, already I told you the successful, repeating once again. So, after normal BMI. So, when you give TOLAC, you can have two options, right? So, TOLAC can end as a successful vaginal delivery or there can be need of cesarean section. Most important predictor of successful vaginal delivery is if she has a previous history of successful VBAC. Okay, and for cesarean section, if there is an impending rupture of uterus or already the rupture has occurred, then it will be resulting in cesarean section. Clear? Yes. So, with this we will be completing this video. We have learnt about what is cesarean section, what are the incision given, what are the layers of the abdominal wall, what are the indications, what are the contraindications, and also about the previous cesarean section delivery. So, with this we will be completing this video. Until we meet in the next video, take care, happy learning and bye-bye.